Did you know each teaspoon of stool contains 100 billion microbes, which contains so much bacterial DNA that today's highest capacity thumb drives would require 100,000 of them to store that data? I'm Dr. Natalie Scheeler. This is Dr. Mary Pardee, and today we are talking all about stool testing.
Poop testing, here we come. I have never heard that fact, and it's fascinating. I love
Yeah.
it though. The DNA piece, I think, is something that we don't talk about enough. We always talk about like 100 trillion microbes or, whatever it is. But the amount of DNA that they contain is really, really interesting. I'm super excited to talk about today. It's something that I'm like uber passionate about because I feel like it's something that's not talked enough about in the space of integrative functional medicine, naturopathic medicine, in general, where there's this kind of elephant in the room of like, is this stool testing that people are doing useful? What are we actually looking at? Are we able to look at the bugs that we think that we're looking at? And when may it be useful and what's useful? So there's so many different tests, and how to apply it to clinical practice. So I'm really, really excited. We're going to cover all of that and so much more. As I was prepping for this, I did a PubMed search of just the gut microbiome, just that. And it was really interesting where in 1956 was like earliest that PubMed would go to. And so I just looked at just the year 1956 to 1957, and one article was there. And then if you expand it to, there is no limits to today, there was 170,000 results. And that's not that much time that's passed from
Yeah.
1956. It's incredible, like the explosion of information that's come about the gut microbiome. And it's exciting for us for sure.
Yeah. Yeah. Super exciting. And I think the public, just as much as the scientists, are excited about it. I feel like stool testing is one of, if not the most commonly asked question I get is are we going to do stool testing? Should we do stool testing? Do you order stool testing from patients?
That's really true. People are calling in, they're asking if we can order it for them. They want it. And a lot of what you do is educate around, well, here's why I would, or here's why I wouldn't. And so we wanted to provide that and bring it here today so people could get an understanding of when stool testing may be appropriate, when it may not, and what are the nuances in between. But that reminds me
Mhm.
of another thing. I also Googled stool test from home, and these stool tests aren't cheap. So you can order yourself a stool test right now if you wanted to. There's a million companies that do them. And for the most part, we're talking about these comprehensive stool analyses when they're done direct to consumer. And they range from, I think the cheapest one was like $70 or something, up to five, six, $700 for each of these
Mhm.
tests. It's really wild how much people are charging for these.
Yeah. And a lot of these companies are really good at marketing too. They'll market it that this is a checkup for your baby, specific stool test for children, for your pets, for tell kind of market that they can tell you all of these things from the stool test. And so there's a lot of information out there that might be misleading, which we'll talk
Yeah.
about.
Yeah, let's definitely get to that because I think that's really important is the claims, right? Like what people are saying.
Mhm.
It's like lose weight by doing this stool test, figure out what to eat by doing this stool
Mhm.
test. All of these things that are like, where is this coming from? And so let's definitely dive in, but let's just general background. What is the gut microbiome?
Yeah, great place to start. So in general, just as a refresher, we have for our, when we're talking about our microbiome in our digestive tract, we have our stomach that feeds into our small intestine, feeds into our large intestine. And I do have a image here that I can share. And so if you're just listening to this, it may be helpful to go onto YouTube so that you can see the video, so you can see this picture of what we're talking about here. So we have our esophagus here that feeds into our stomach. The stomach feeds into this small intestine here and then wraps around to this large intestine, or AKA colon. And as I mentioned, when we talk about our microbiome, we're largely referring to this large intestine because that's where the majority of those microbiomes live. We see here density-wise 10 to the 12th power of microbes in our large intestine. We have the least up here in our stomach, 10 to less than 10 to the third, and it starts to pick up as we move through the small intestine. and then when we get to the colon. The other important thing that's helpful to look here is that with our small intestine, this is where we tend to see the lowest diversity of microbes. And so as far as difference of species, we have least amount there in the small intestine, and then we get that greater diversity when we are in the large intestine here. And even broader when we're talking about the microbiome, what we're referring to. So that includes things like the bacteria, fungi, viruses, all that kind of are housed in our digestive tract. And today we'll be focusing on that digestive tract. There are other microbiomes in the body that there are actually tests for too, like vaginal microbiome, that are available. However, there's differences in kind of the limitations and testing of that. So our conversation will largely focus on that gut microbiome today.
Awesome. And let's talk about what diversity means. I think it's a word that we throw around a lot, but I want to make sure people understand the word diversity. And also just, well, before you say that, that photo, if you guys reverse, there's not an actual hole in the colon. So it's
Oh,
just,
yes.
they took out the transverse colon, that middle section of the colon, so that you can see
Yes.
the pancreas back there and the bile ducts and all of that. But
Yeah, just so we
for
can
effect,
see
yeah.
behind it. But this is usually connected here.
This person would have GI issues. Faux sure.
Yes, definitely. They'd have more than GI issues.
Yeah.
Yeah, so to answer your question about diversity, so there's actually two types of diversity that we talk about and refer to. There's alpha diversity and beta diversity. Alpha diversity is how diverse the organisms are in your own gut. So essentially, how many different types of organisms are we seeing bacteria? And then beta diversity is how different does your microbiome look from other people's microbiomes? What we really care about and research has shown is that alpha diversity is more important. Having a more diverse microbiome personally is shown to be correlated with better health outcomes. There is a large, we will dive into this, but there's a large spectrum of what the health kind of quote unquote healthy microbiome looks like from person to person. So beta diversity is less important. When I'm talking about diversity, I'm referring to that alpha diversity.
Great.
In general, unless I say otherwise.
Yeah. And then let's talk about the different phyla that are in the intestinal, I guess just bacteria in general, how we classify them.
Yeah, talking about phyla, we're talking about bacteria, and bacteria is the majority of what is in our gut microbiome. So that is largely what the research surrounds and what we have at this point. And so again, largely what our conversation will surround today. But so when we're talking about phyla are essentially kind of families, and there's two dominant phyla in the large intestine, and that's Bacteroides and Firmicutes. In healthy people, those two phyla can range from 10 to 90%. But what we see is that the combination of both of them equates to about 90% typically. And so what that means is that you could see the Bacteroides be 10% and we see the Firmicutes be 85%, or vice versa, but we tend to see around 95% of those two phyla together. There are a few other ones, including proteobacteria, actinobacteria, fusobacteria, but the Bacteroides and the Firmicutes are the dominant ones.
The two big ones, yeah.
Mm.
I like the family is like a different taxonomy, but I like the idea of that because it's like, you know, like who are like, I mean, gang would be another one, like who are the
Yeah,
classes.
they are the
I like that.
categories where they have similar characteristics to other members of that group.
Yeah.
Is how the phyla is officially kind of defined.
Yeah, that's good. Okay, and then when we talk about stool testing, we're going to get into the science a little bit. If you don't care about this, you can probably fast forward as well. But for those interested, there's a bunch of different ways that we actually test the stool to figure out who's in the stool. There's different methods, and some of them are older, some of them are much newer, some of them are less accurate, some of them are more accurate. We'll talk about sensitivity, but let's go through the basics and start with like stool cultures and what that looks like, and then we'll kind of go down the list.
Yeah, so stool cultures are the kind of traditional method for culturing bacteria, and essentially what we're doing is we're culturing out the bacteria. We're using some media that will promote the growth of these microbes, and then we count them, and that's how we determine how much are present. The culture is a traditionally used. However, one of the difficulties with culture is that it's difficult to culture out anaerobes, which are the microbes that thrive in a non-oxygen environment or only survive in a non-oxygen environment. And that is the majority of what we see in the large intestine is those anaerobic bugs. So it's really difficult to do it. It adds time, it adds dollars to the testing, and it is a harder thing to do for some of those gut microbes.
Yeah. And we were doing cultures, more commonly a while ago, and we switched a lot of the cultures to PCR. So let's go into PCR next.
Yeah, so PCR stands for polymerase chain reaction. And essentially, what PCR is a photocopier of DNA. They take these small pieces of DNA, create a lot of copies, and then we have enough material so that scientists can use them, see how they interact. Essentially, just a photocopy in plain terms. And just sorry, one more thing about PCR. That is helpful because they can pick up what culture misses. They have good sensitivity and specificity. Sensitivity being if something is there, it'll pick it up. And that specificity is if it shows positive for that microbe, that it truly is that microbe and that it's not a false positive. So those can be really helpful.
Yep. And I looked up yesterday, culture has a sensitivity of about 33% when you compare it to PCR, which is pretty low when we look at, rates of false negatives, right?
Yeah. And that's something too. So culture can be, there's always going to be a certain level of bias with culture because of the media, the essentially what we are giving to the microbes to grow so that we're able to count them will certainly support, there's going to be environments that support some microbes better than other microbes. And so there's always just going to be a certain level of bias when we are doing culture.
Right. If you're using the same medium to try to culture multiple things, is that what you're saying?
Yeah, and that's certain media promote growth in certain microbes more than others. And then with the anaerobe side, the bugs that thrive in an oxygen-free environment, you lose things through that process because we have to keep them alive in order to count them versus looking at their DNA or whatnot.
Yeah, great point. What are the other big ones that we want to talk about?
So a few other ones. One is called enzyme immunoassay, which is one that many people might be familiar with. It's short EIA. You might see this lettering next to some labs that you've had done before. So this is commonly done with things like H. pylori, Giardia, sometimes C. diff. And so you'll see this type of testing in conventional labs. This type of testing, it looks for substances that the bacteria or the microbes produce versus looking at the microbes themselves. And the benefit of this guy is that it can be done really fast, and it's usually done in a few hours. So it's helpful in a clinical setting of if we want to get that, if somebody's coming in with symptoms and we want to get that diagnosis quickly turned around.
Great.
And then next common one is something called amplicon sequencing. And so what this does is it looks at a small part of the genome, so a small part of the DNA. And so if you picture the DNA of a microorganism as like essentially a book, we are taking a chapter and we are reading that specific chapter to look at that organism. We're focusing on that one chapter versus the entire thing. And so that is another commonly one done, a type of amplicon that might sound familiar and is commonly done with direct-to-consumer stool testing is the 16S sequencing, which is just looking at a specific marker in bacteria. But that one is one that we'll commonly see. And then similar to that one is shotgun sequencing, which instead of that one chapter, we're looking at the complete genome. We're reading the whole book. And so this can be really helpful because with the partial genome sequencing, we compare that to a kind of set list of microbes that we know. And so if we're testing this one stool, we're typically testing it against, say, 200 microbes that we have in this set list. And so if any of those 200 microbes are in there, we pick them up. If there's things outside of that kind of key list that we have, they can get missed. And so shotgun is different, is that we don't use that kind of quote unquote key. So we pick up what is there. And so we can get things that get missed with some of those other methods. The difficult part with this is it's more expensive. And so generally not as frequently used in clinic or in research just because of that cost.
Yeah, there are some direct to consumer ones I know that are using the shotgun, and
Yeah.
they're more expensive for sure.
Yeah. And then the last one is metatranscriptomics. And so this one, again, is seen in some of those direct to consumer labs or products, but this is looking at the mRNA of the microbes. And so essentially it's looking at gene expression versus just what microbes are present. And so I kind of compare this to, we're looking at a library and we have a list of all of the books. And so meta transcriptomics looks at which books are currently being read versus just the list of everything there. Does that make sense?
Yeah, like who's active, what are they
Mm-hmm.
doing versus
Yeah.
just the name itself,
Yeah.
just who's there. Yeah. Which is really important because the activity is a huge piece of this, which we'll talk about. And if you're listening and you're like, oh wow, the test I was gonna get uses, the shotgun, or it uses the fancy one that tells me what's happening versus who's just there. That's not the whole story. So we want to dive into like, is it even useful still? Like, can we make
Mm-hmm. Mm-hmm.
actual changes? Are the guarantees that they're saying even possible with the information that we know yet? So let's dive into more of the fun stuff. Well, you made that pretty fun. I was actually pretty impressed with your analogies. I'm like, how is she going to do this and keep my attention?
I know you could definitely get lost in some of they're all similar and different, and yeah.
Yeah. Um, and so my first big question for you, this is like very big picture. Can we accurately test the gut microbiome right now with the science that we have?
Short answer is no. And so there's a lot of limitations, and we can kind of just jump right into them. But the large takeaway is no. One of those biggest limitations is that quote unquote of an ideal microbiome that you asked. And so there is no ideal microbiome. And so there's an incredible amount of diversity from person to person, including in healthy individuals. And so we kind of mentioned this earlier with the Bacteroides to Firmicutes ratio, is that we can see significant ranges in the bacteria and people quote unquote still be healthy. And so one person, we might see a relative abundance of a certain bacteria at 5%, and then in another individual, that relative abundance is less than 1%. But in both individuals, they are healthy. And just quickly, because I don't think we did define this part, relative abundance is looking at what the amount of one microbe in comparison to the total number of microbes present. And so a ratio versus counting out, like there's just to oversimplify it, there's 5 of these of bug A and 5 of bug B. And so it's just the percentage of the total present. And so the sheer diversity that we see from person to person is so significant. And so we have to be really, really cautious with how we interpret data. It's different than some of the other lab work, blood work, where we do the reference ranges, where we see 95% of a population fit into these kind of reference ranges. And so we know you're above that, oh, your blood sugar is high or your blood sugar is low. And unfortunately, microbiome is way more complex than that. And so we don't have those reference ranges. Another piece to that too is sometimes when we're looking at that research, if certain studies are finding correlations between certain microbes and conditions or whatever we're looking at, if they've used like less than hundreds of people, we have to kind of question how valid it is because of that such significant diversity. And so it makes it difficult. It's not the same as it's apples and oranges compared to reference ranges that we have for other testing.
Yeah, I think that is so important to stress, right? And I think like if we want to like oversimplify it and like have an analogy, think about the idea of like how do you determine the health of a city? If it was your job to determine what's a healthy city and what's an unhealthy city in terms of how many doctors do you need, how many train drivers do you need, how many um people that pick up the trash, how many people that clean our water, how many nurses do you need, how many teachers do you need? You can see, right? Like the list is how many professions there are, and then ask how many cats you need, how many dogs you need, how many birds do you need? How many insects do you need? How many da, 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 da,
Yeah.
da, right? And that analogy is of the gut microbiome, where it's we have all of these different players there. Like think of, you have some doctors, you have some things producing things, you have some factories, you have people that are consuming the things from the factories. And to determine the ratio and the amount of each that you need to have a healthy ecosystem is super complex. Like it's
Hmm.
such like a huge question to answer. And I think, like you said in the beginning, we don't know the answer to that question yet.
Yeah, certainly. And I really like that analogy. I think too, it can be used to show that the microbes too are functioning and interacting with each other, and there's overlap between how certain microbes can act. And so, using your example, if we're looking at a city and say one city has 5 doctors and 5 nurses, and they work really well. Well, city B might have 1 doctor, but 3 nurse practitioners, 2 PAs, and no nurses, but that works great because they're able to kind of cover and do the same tasks that the 5 and 5 in city A are able to do. And so I really like that example. I think it helps
Oh wow,
exemplify.
you
Yeah.
like supercharged it though. I'm like,
Yeah.
so good. I was like, where's she going?
Yeah.
Yeah, it's phenomenal where it's like you can have, Joe and Sandy and their microbiomes look totally different and they're completely healthy and nothing's wrong with either of them, right?
Mm.
So, yeah, it's like fingerprints. We don't look at your fingerprint and then look at my fingerprint and say, Natalie, yours is wrong, or we need to
Mhm.
change your fingerprint. It doesn't look like hers, right? And so
Yeah.
I think we have to start to realize that, and I'm one of these people, but I love like answers. Like I want to know a level. Like I want to be able to say good, bad. And this is where the medical sciences kind of are fusing into potentially like art too, are we ever
Yeah.
going to find this answer, or are there going to be a bunch of different answers potentially of what can be healthy?
Yeah, certainly. And yeah, even more so if we go further with some of these limitations is when we're doing these tests is what are we actually looking at? What are we measuring? And so we're using stool for these samples and for these tests. And the reason we use it is because stools are relatively easy and very accessible to access. But does that really reflect what our gut microbiome looks at? And so the answer to that is not completely either. And so we have microbes in our digestive tract. So there's some microbes that we call mucosally adhesive, which stay along the lining of the intestines and don't leave with the stool. And then we have lumen-based bacteria that more oftenly kind of exit in the stool and that we see come out with the stool, and so that we are able to test in the stool. And then the other piece of that too is that when we have a bowel movement, the stool stays in our rectum for a period of time, and in the rectum it ferments, and so that promotes growth of certain microbes that to higher levels than what it looked like higher up in our digestive tract earlier in that large intestine. And so that can change what we see in the stool as well. And so another thing to think about is what are we actually testing and what are we seeing when we are looking at these.
Yeah. Yeah, great point. And this is where like the analogy of the city, it now becomes a moving city that also is changing. Like it's like LA is not staying in LA. It's like, moving across the world, and air is coming in versus when there was no oxygen before, right? And so you see
Mhm.
this huge um just evolution that can occur in a city so quickly, from like the time that you put something in your mouth to the time that you go to the bathroom. It's really fascinating and adds a whole nother level there. One
Yeah,
of the things I
absolutely.
wanted to jump in and talk about too is the question that you just said of like, who are we actually looking at? Um, this is one of the things that I think is important to realize is when you're looking at these stool test results, and if you guys have them at home, like now's a great time to pull one up and just look at what I'm talking about here. But these are talking about, again, these direct to consumer tests, or, the ones that your functional medicine doctor ordered for you even. And if you look how they lay things out there, you have to understand something called taxonomy. So if we think about bacteria, the word like the bacteria is itself a kingdom, right? We have the kingdom of bacteria, just like we have the animal kingdom. And within that kingdom, we have more and more classifications that make things more and more specific. So I want to take it like the most common bacterial example, if there's a common bacteria, but like somebody that you may know is E. coli, in terms of E. coli 0157H7 is, a common E. coli strand that causes foodborne illness, diarrhea. And if we take that as the example, the phylum for that is Proteobacter. So E. coli goes under the Proteobacter phylum. And then the genus is Escherichia.
Let me share my screen because I have a helpful picture for you too
Oh,
with
great.
this guy.
I skipped a few, but we started with phylum as Proteobacter, and then, we go down to genus, and that's where it's the Escherichiae, and there's a lot of different consonants in there that make it difficult to pronounce. And then you go one further, and it's species, and the species is E. coli. So that's going to be the species level. There's actually another step, though, where we can then go to the strain level of that species, and that's where it's E. coli 0157H7. And if you compare that E. coli with another E. coli, which we can use the example of E. coli Nissl 1917, those are two different strains from the same species. And they have very different actions when they're introduced to the human microbiome. Whereas if you have enough of E. coli 0157H7, you can get pretty bad diarrhea and a really not fun experience. Whereas if you take E. coli Nissl 1917, it's a probiotic and can have some beneficial effects for some people, and we can actually use it medicinally. And this is the same species that we're talking about here. And so when you're looking at your report, if you just glance and see a lot of what they're listing there are the species level, they're not getting to the strain level. And, it's like a big fancy word, but that big fancy word is still pretty broad. So we need to realize that some of what they're saying is like, okay, cool, you have this much E. coli, but who's actually there? Is it a good guy or is it a bad guy, or is it a conditionally good guy or bad guy that depends on if they're producing a toxin or not a toxin? Or the amount of nuances that go into these is really important, because you hear doctors say like, oh, that's too much to have of that genus. It's like, says who? There's no research that says that. Like, these are claims that are being thrown around in the functional medicine space that have very little to, if any, science to back it. And I think people just like to have information and numbers. And if you're that person, like, great, do it. But like, can we actually make good clinical decisions based on this information as a whole different story? What are your thoughts on that?
Yeah. Yeah, no, I completely agree. And I think this kind of references some of the conversation we've had in some other videos talking about how that kind of good guy, bad guy isn't as black and white as we once thought. And there's a lot of gray. You mentioned with the conditional microbes, and that in certain situations that microbes can act differently and they can act pathogenic and cause disease in certain situations, but then not have that action in other situations. And so I think that's important. And one of the things that I do see is that when people either come in with stool tests or have stool tests for whatever reason, and we see one of those bugs that can be a pathogenic bug, but they're not having any symptoms of the disease that it causes, it can lead to anxiety of like, oh, I have this present, I want to get rid of it, but it not be an issue at all. And so even just the act of getting rid of it, whether using antimicrobials from antibiotics or herbs, can lead to have detrimental effects too. And can lead to an imbalancing of that microbe that was kind of keeping everything steady and safe. And so it just something to think about as far as whether that's going to raise anxiety if you see something of a quote unquote bad bug present on the testing.
Yeah, such a great point. It's like the city was doing actually okay, even though it had some members who potentially could be bad guys, but in that city it was actually doing just fine, but we decided to drop a bomb in it just in case. But the aftermath of that bomb created more havoc than was there even before, right? So
Yeah, yeah.
nuanced. Let's also talk about If somebody does a stool test today and then they do it in 3 months, is the result stable over time?
No, our microbiome changes. I get a lot of no's today. So our microbiome changes every single day. And how much it changes varies depending on kind of what's happening, but the microbiomes are dynamic. And so things like medications, things that we're exposed to, foods that we're eating, medical conditions that we have, all of those things can change the microbiome. And example for the medical condition, for somebody with inflammatory bowel disease, we can see before a flare that microbiome can shift. It varies from day to day. And so when we are doing a stool test, we're taking one snapshot in time. You can have different results from your morning bowel movement if somebody has a bowel movement in the evening. And it can look different. It certainly shifts and changes over time. And that's one thing too that we think about if you buy this test and you see certain levels of microbes and may have concerns that the balance or this is present and this is not, et cetera, et cetera. And so we make these changes, whatever we choose to do. And then we retest that, kind of think about how much is from what you were doing, whether was herbs or probiotics or prebiotics or whatnot, and how much of it was tincture of time and just the exposure of just living life, and another kind of complexity of how to use these in it clinically.
I love that you said so. Like, if you did a stool test in the morning one day, and then you did another stool test at night, you could potentially get two very different results, right?
Yeah,
Which
certainly.
that alone, like that says a lot, right? And it's
Mhm.
not bad. It doesn't mean that like someday we won't be able to figure out like how to use these, but I think that says a lot. Whereas you could wait 12 hours and get a different result entirely.
Mhm.
Or you could eat all McDonald's and pizza today and do a stool test, and then 2 days of eating just fruits and vegetables and do another stool test and have two different results. And it doesn't mean you're sick and dying today and you're, of 100% vitality tomorrow,
Mhm.
right? We're dynamic
Yes,
creatures.
exactly. 100%.
Um,
100%.
Do you think testing the microbiome is the best way to actually, or testing the stool is the best way to look at the microbiome? Or is that kind of, I think that might be what we talked about before.
Yeah, well, so there's certainly limitations with stool. I guess, I mean, the setting matters. It depends on what your goals are. And so with a clinical setting, stools are accessible. If somebody's coming in with acute diarrhea and we're trying to see what's going on, if we think there's infectious cause that we need to test for so that we know what to treat, then stool testing is great. If we're trying to get an accurate representation of what the microbiome looks like on a day-to-day basis, that's difficult. You can do biopsies of the intestine for the microbes, but again, there are limitations with that, as to it's similar to what we've talked about before, is what part of the microbiome or what part of the digestive tract are you testing, contamination, all the limitations that we talked about with testing, all of those still apply. So there's difficulties there too. And that actually triggered light bulb for me is another thing we didn't mention above, is that a lot of times when patients are coming in asking about stool testing, it might be for something like bloating or belching, increased gas, some other kind of digestive symptoms that are not necessarily from the large intestine alone. And so when we're doing these stool tests, what are we looking for? Where the pathology is, like where the problem is. If the problem is in the small intestine and we're looking at stool, we're very far away from what's going on there. And if it's even more so the stomach, if we are kind of testing the stool, the one asterisk for that is that we can test for the H. pylori in the stool, which is present in the stomach, through that EIA because of the toxins. But otherwise speaking, as far as just we're looking for like the quote unquote good guys, and we're testing the stool for something that's higher up in the digestive tract, very far away at that point from what we're really trying to look at.
Yeah, yeah, all really good points. Let's talk about the interpretation of these results. I think we've already kind of covered it a little bit, but when we get the stool test back, how are we deciding if we're going to interpret it or how we would interpret it?
Well, I think where we are in general in the point of research is that we know that there's correlation between certain microbe changes or patterns in the digestive tract to to certain medical conditions, but we're not at that point of causation. And so if we see where I think a lot of this stool testing goes wrong is that we see one bacteria be high and there's concern about histamine or something with that. And so, okay, it's high. That's the reason that you're having these symptoms. We have to eradicate it, and then your symptoms will be solved. We took that one step too far, or multiple steps too far, but we took that from the correlation to the causation, which isn't where we are yet with research. And we can talk about this too a little bit at the end, as far as kind of, I think you're more on the never test and I'm on the with exception sometimes test. And so large scheme of things is that when we're interpreting these tests is that we can't get caught up with the minutia, and that maybe looking at patterns could be helpful. But again, still very early in that research, there's a lot of confounding factors that we have to think about. Age, diet, drugs that you're on, background, living environments, ethnicity, all of that has to be taken in account. And we don't have enough research to really have a reference point to compare those things to.
All great points. And I do want to get to that eventually too. But I think it's important what you pulled out where you said, people are saying, you have, this there, and that's associated with this. So let's treat it. We have to be super careful when we start talking about correlations, associations. I remember one of our professors in school gave this analogy, which really stuck with me, where it's like, on summers where it's really hot, there's an increase in deaths from drowning, and there's also an increase in popsicle sales. But we would never say that popsicles cause drownings, right? But it is associated with more drowning deaths.
Yeah,
More popsicle
yeah.
sales, more drowning deaths. Oh, we should get rid of the popsicles and that'll solve the drowning deaths. It's like, no, that's so obvious that that's not the cause. It's just they both happen to be there at the same time. And I think the microbiome, you can kind of think of it the same way, where it's like, is this just an innocent bystander who happened to be there? Or is this a causative agent that's actually contributing to the pathology and the symptoms? And those are two really different things. And we have to be cautious because, we do see all these practitioners, people come to us all the time, and it's like they've been on a million protocols. They've been on, kill protocols or 4R protocols, or I've had somebody come to me that they had been on a parasite cleanse for 2 years.
Oh, geez.
No positive parasite test. And I think that there's just a lot of stuff that's going on where there's potentially and like a good chance that there's a better option for quicker treatment that's more based in evidence and science versus treating with tests that aren't validated yet, that we don't have enough information about, yada, yada, yada.
Yeah.
Let's go into key takeaways here and kind of summarize, because it was a dense, fun talk. But what do you think the biggest takeaways are? And then let's talk about our personal, you've already gotten a bunch of my
Yeah.
opinions.
Yeah. Well, yeah. Well, so I think that the key takeaway is that we're still in the infancy of research. I actually was just at a conference, and one of the discussions, there's scientists talking about kind of microbiome research, and he had some pictures up on the screen, and he was like, if I was to show you a picture of kind of the excitement of where we are for microbiome research, it was a picture of the Super Bowl and Travis Kelce and Taylor Swift. And so everybody's all excited and talking about it. And then he was to say where there was a picture of kind of where we are as far as the science goes. And it's a bunch of kindergartners in a classroom. And then the third picture is where we are as far as making clinical decisions, as far as based on the research that we have. And it was a picture of a fetus. And so we are still in the very infancy of this research. And so there's a lot of really exciting research, and it's super cool to read it and see it. And I think the gut has a lot of information that we're just kind of scratching the surface on. But to be really, really cautious about the decisions that we make based off on that research, and especially in that clinical setting, that it is likely too soon to make a lot of those decisions that we are off of the information that we have, and that there's a significant amount of limitations with where we are today.
I love that analogy. Like just like those three different kind of ideas or like pictures, I think are so
Mhm.
spot on because it is exciting. And like you
Yeah.
and I both love conferences and learning more. And there's so much fascinating information that's coming out about this. So by no means is
Hmm.
this to poo-poo or, to dampen any of that because it's fascinating. It's like a whole
Yeah.
ecosystem that we have inside of us. And just because it's fascinating and interesting and we're learning so much doesn't mean we know enough to then go apply it right away, right?
Yeah, exactly. Yeah. I think another thing I hear from patients' experience is that they may have seen a provider before and had a stool test done and done a course of treatment and had benefit for at least a short period of time. Generally speaking, some symptoms are back if they're in our office to find themselves in our office again, but they had benefit from that stool test. And so they're like, okay, I want to do another stool test because that was helpful before. My mentor kind of used this analogy with me that I find really helpful is that when we were first explaining astrology, we started where there's probably a lot of models, but one of the early models of kind of how we conceptualize the universe was the geocentric model. And with that, the Earth was at the center of the universe. And it worked for certain things that explained why no matter where you were on the Earth, we saw the sun once per day, and that the moon had its own cycles and the stars and et cetera. And it made sense of a lot of things that we know to be true. However, it obviously wasn't 100% correct. And so I think when we do those tests and if we use herbs, a lot of the herbs have more than just antimicrobial action. They have other benefits too, that they can be carminatives, help with gas, anti-inflammatory. And so we might see benefit at some amount of time with doing some of these things, testing, kind of quote unquote treating, but do we really understand what's going on that led to that benefit? I don't think we have that full understanding of where we are right now.
Yeah. Yeah. Great point. I think to build off of what you said, you can do the same treatment and get benefits, not because you were treating the thing you thought you were treating, but because you were treating something else and it happened to get better, which is not to build off of, it's literally just a summary of what you said. But I think a lot of that's actually what's happening potentially is people are coming in with SIBO, and instead of doing a lactulose breath test, which potentially can be covered by insurance, you're doing a $600 stool test for the person. And you're seeing, oh, all of these levels are elevated. It looks like, you have overgrowth of this, we have to kill it. And you're doing antimicrobial herbs, which we know can be helpful in treating SIBO, and the person gets better. And so the
Mm-hmm.
test was worth it in their mind, where they could have got a free test or nearly free,
Mm-hmm.
more information about what was actually going on, and a narrower target to focus in on, because if the symptoms come back like you said, they're going to want another $600 stool test, and now they're 1,200 in and potentially could have been covered by insurance, which kind of is ouchy. Let's go into our thoughts around stool testing. Let's first talk about the comprehensive stool analysis. So, like, do you ever order those, looking at the microbiome and things like that?
So I'm not a complete never. The only time that I order stool tests outside of what we kind of mentioned as far as acute symptoms, where we're kind of going through conventional labs to see if there's a pathogenic bacteria present, or parasite, or whatever we're looking for. I occasionally do the whole genome sequencing, the shotgun sequencing testing, because I do work with patients with fecal microbiota transplant. And so for some people, it is quite an investment to do that. As far as time, money, screening, it's not an easy process to do. And so with that, they're looking at the alpha diversity, which I feel like we do have a strong body of evidence that shows us that alpha diversity points to better health outcomes, especially in inflammatory bowel disease. And so doing those testing can be helpful to see kind of what their microbiome looks like. Do we think if there is some markers of kind of poor alpha diversity, or some other correlations? If the patient understands that it is correlations 100%, not causations, that we are taking it a step further than where we have comfort as far as research goes, then I think that can be helpful to make that decision. Okay, I do want to proceed with the FMT. It's worth it for me because maybe I will be a better responder. However, we don't have research to support whether somebody's going to be a better responder or not from FMT in any kind of condition. But I find that when we are kind of working in a little bit of outskirts anyways, that it can be a helpful decision maker for some.
Yeah. And I think you highlighted a few really important factors, which is you're educating the patient on what it is going to potentially tell you, what we know, what we don't know. And you're saying pretty much how it is, where it's like, hey, I think that this might be helpful, and this is the best technology we have currently. Here's what we could potentially learn. And we're not working off of something that we know as a hard and fast rule, right? So,
Hmm. Hmm.
and I think if that education was used with all patients and all providers, and I understand like there's limited time to do these things, but I think it's really important that people know what they're getting into in terms of, is this validated? Is this not validated? Um,
Yeah.
is this 100% truth, or is this, we kind of think, hope, and cross our
Hmm.
fingers kind of thing?
Yeah.
Somebody
Yeah.
goes in like informed, I think that's a totally different thing than going to a functional medicine doctor, them saying, hey, you got to spend $1,200 in labs to get the answer if you want to get better. Like those feel like two very different experiences for the patient.
Yeah, 100%. And ultimately, I do think that I think my role as a provider is to give the information to the patient, and the patient can make the decision of whatever they choose, testing, treatment, et cetera, that fits their healthcare preferences and their desires. And so, as far as just like, having a patient informed so that they can make the decision
Yep.
comfortably and have all the information to make an
Yeah,
informed
and
one.
I'm in 100% agreement with you there. I always tell people, here's why I wouldn't do it if I wouldn't do a stool test like this. And I'm going to send them this video so I don't have to spend time on it. But like, here's why I wouldn't do it. It's not validated. We don't know enough to even come close to making recommendations on the gut microbiome. But it's your body. If you want to do it, then sure, we can do it. I don't know if it's going to change what I'm going to suggest clinically, but I also think having autonomy with your body is really important.
Certainly. And being able to just to read through some of the that if they're doing it through a direct to consumer lab, that they can hopefully read through some of the claims that some of those labs will make about eat this food, not that food, et cetera, just ignoring all of that. We don't, that's entirely not valid. But so having some more background to be able to decipher what to pay attention to with all of that too.
Yeah, we probably should do a whole nother video about the claims that are made, and are they remotely true, or are they completely away from there? Most of them are like based on some crazy ideas that I'm like, I don't even know where they came up with this or found this, but I think that
Yeah.
we can do another video on that. And then I also want to like really highlight the fact that we're talking about stool tests for the microbiome with most of what we're talking about today. You and I both run stool tests all the time through Quest, LabCorp, covered by insurance, looking at levels of calprotectin, which is an inflammatory marker. Sometimes we'll do fecal occult blood to see if there's blood in the stool. You look at things like Giardia, oviparasite tests with people with diarrhea, looking at, PCR tests for other pathogens that could be potentially there. So we do stool testing, and it's an important part of clinical practice, but these are going to be the more validated tests that have been reproducible, and we know what information they're giving us and are covered by insurance and aren't super expensive, and all the things, right?
Yeah, exactly.
Any
Mhm.
other additional things that we didn't talk about that you think are really important to mention?
I think we covered it. I feel like we covered quite a bit.
Awesome. This was amazing. I learned something, so thanks for like all the thoroughness and all of your analogies and stories. Really, really fun. I hope it was helpful for everybody listening. Dr. Scheeler has done a bunch more videos on everything GI, so go to our website, take a look at some of the other ones there, and message us, email us with any questions or other topics you want covered. And thank you so much, Dr. Scheeler.
Yeah, absolutely. Thank you for having me. I'm excited to see what questions might pop up from this.
Same.
I'll happily answer.